All right. Well, good morning, everybody. Welcome to our conversation today. Keeping the doors open, practical plays rural hospitals can execute now. We're going to explore some of the effects and solutions for recent funding changes to the healthcare system that's affecting rural hospitals in particular. My name is Rob Schenk with Intelligent Technical Solutions. And here at ITS, we specialize in helping small and medium sized businesses thrive by managing and securing their technology. A few housekeeping notes. Conversation should run about 30 or so minutes. We'll stick around at the end to answer any questions. The conversation will be recorded. If you'd like to review any of the information later at your convenience, and we're happy to take questions. Please go ahead and click on the Q&A button in your Zoom toolbar, and you'll go ahead and be able to submit those questions. All righty. So let's get going here. You'll notice a QR code in the slides. That's going to lead to a special offer page for attendees of the webinar. So in case you need to leave early, you might want to scan that for later. And for today's discussion, I'd like to welcome our very special guests, Doug McCoy, CEO of Eastern Plumas Healthcare. He's a champion for rural hospitals navigating today's tough environment. Dr. Paul Swanson, he's EPHC's medical director, and he brings a clinician's view of how policy impacts patient care. And I'd also like to welcome Cody. He's Health IT Team Director here at ITS, Healthcare First Technologist, who's bridging the gap between clinicians, billing, and IT systems to stop revenue leakage and improve efficiency. So I'd like to welcome you all to today's discussion. All righty. With that, let's get started. This session is going to be practical. We're going to be built for the realities that rural hospitals and healthcare facilities are facing right now. So quick overview of today's topics. We're going to talk through what's recently been changing in the healthcare industry, an overview of the HR1 or Big Beautiful Bill. We'll talk through some of the stakes and challenges that we all face now. We'll also talk through some practical solutions that are helping hospitals kind of navigate some of these adjustments and changes. And then we'll also review the human factor. We'll talk through some culture, care, and community, along with some key takeaways that you can implement right now to lower your facility's exposure. So, Doug, let's get started here. Let's talk about the big picture. So, how is the Big Beautiful Bill or HR1 changing the financial outlook for rural hospitals like yours?
Well, I think going back in 2024, I read a study that stated over 450 critical access hospitals in the US were at imminent risk of closure. So we're here based in California, but in California, Medicare and Medicaid only reimburse about 70% of every dollar that we spend to provide services. So hospitals were already operating on extremely thin margins to begin with. HR1's created the most significant change to hospital operations that we've seen in decades. And in our case, 40% of the population that we serve is on Medicaid or Medi-Cal in California. So we're anticipating through HR1 losses over $4 million annually beginning in 27, 28. In addition to the funding reductions, California is estimating that 1.8 million of the 15 million people that are Medicaid recipients will lose coverage under HR1. So, if we apply those estimates to our area, this means that 12% of our patients will no longer be covered under the program. Also, the change in eligibility redeterminations changed from annually to every 6 months, which increases the potential for Medi-Cal recipients to drop off the Medi-Cal rolls. And that places more pressure on the hospital's need to assist these patients with their eligibility application process. So we've spent months analyzing the data and creating forecasts. But one unknown issue that we are all facing is with those people falling off of the Medicaid rolls, what's that impact with uncompensated care going to be for hospitals and hospital systems to still continue to assist those patients that are no longer covered but still require medical services? So this is a significant issue that we're all facing right now, and how to navigate that going forward.
Yeah, that's pretty significant indeed. I guess, Dr. Swanson, from a clinical perspective, what do these funding cuts mean for like day-to-day care delivery and staffing? Any changes there that you'd see?
Th there's different sides to that. In terms of care delivery, hopefully, there won't be much of a change. Most of the clinical care is delivered without immediate reference to the costs or billing. However, for patients that no longer have insurance, there's a big effect. The big effect being mainly that they would have difficulty um, seeing uh, outpatient uh, clinical staff, outpatient doctors, and so forth. Um, we have the basic safety net for the United States is that emergency departments can't turn patients away. And so uh, we would expect that those patients would not seek routine medical care, but would come to the emergency department for any acute needs. And we can handle acute needs pretty well. And if they need hospitalization, they'll get hospitalized. But it just makes for a more disordered delivery of medical care for them, and there's less preventative care and so forth. Um, I'm on the hospital board of directors, and so the big issue I think is that this is going to affect the bottom line for hospitals, and if they don't have, if they're in the red and they're eating to the reserves, the risk is that the hospital is going to, fail at some point in the future if it can't maintain. And so, um, keep finding ways to offset the loss in revenue and stay in the black over the long run, I think is the big issue. Closure of hospital is a major impact upon healthcare.
Yeah, for sure. Cody, you're embedded in with Doug's team over at EPHC. So from your seat, what happens when these cuts meet complex systems like Cerner or CalAIM reporting, and where do hospitals, typically start losing traction?
Well, every hospital, be it a large regional network or a small critical access hospital, they're all hemorrhaging money through all these different processes. So, really, what it comes down to is trying to shore up that boat so that you're not leaking. And the stronger that you are, the better you are set to weather these storms. So, the keys to that is looking at issues with charge capture. Is everything getting on the claim? Is the claim being processed correctly the first time? Is your remittance coming in? So every step in this process needs to work cleanly. And most of the time, there's a hole. So if you can button up those holes and solve a lot of those problems, you have a tighter running ship and it's able to survive this big shift and this loss of revenue.
Yeah, that makes sense. So Doug, we've talked about these. Some hospitals are cutting services, but EPHC is, expanding. Got some new programs and a couple other new services that you're offering. Can you talk through this? How are you able to kind of make this possible in this kind of environment?
Well, as you said, instead of taking a position on cutting revenue, specifically in challenged service areas or downsizing staffing, our strategy is actually to expand. And so we're wanting to continue diversifying into other revenue sources. We are also the largest employer in our area. Many rural hospitals are, and the only service provider in a 40-mile radius. So we feel a intense responsibility to make sure that the organization, both as an employer as well as a provider, is viable for the long term. So, some of the revenue diversification strategies that we've put together, and some of these have been going on for a fairly lengthy period of time. But one is the maximization of any available state and federal grant programs. We have brought in approximately $7 million over the last 3 years through various grant programs. And that's really allowed us to be able to grow services, make acquisitions of equipment or building renovations without cost to our organization as a whole. So that's been very valuable to us. And although we anticipate funding reductions in grant programs, there are still a variety of programs out there, often though they are very difficult to find. So, really going in and mining for those opportunities and then maximizing those to the largest extent possible. Another area that we've really focused on, especially this year, has been the alignment of providers, software, data tracking, and clinic processes to maximize. Again, in California, we have quality incentive programs that are available and that are significant in reimbursing for the preventative care work that we're already doing. But it takes a lot to make sure that all of those are managed um, in sync with one another. And so we've spent a lot of time on that area, and that will continue to be a key strategic area of focus going forward. And then another area that we focused on is just the improvement in our revenue cycle. And that really is from end to end with the goal of reducing AR, both in terms of timeliness of payment, but also the risk and prevention of bad debt. So those are really the key areas that we focused on. But that has allowed us to be able to actually add more services to our community versus take them away.
Yeah. Some important considerations, folks, for folks to pay attention to. Cody, can you walk us through some of the operational changes and adjustments that the health IT team has helped EPHC make, and how what's been the results of some of those modifications?
Sure. My team works pretty much the entire revenue cycle from registration all the way through to mapping to the general ledger. And in that, we can kind of bridge silos. We speak clinician, we speak finance, we speak IT. And because of that, we can leverage that expertise to solve bigger problems that sometimes a small hospital can't. An example that we have on the slide there was reflex labs. Eastern Plumas Healthcare uses LabCorp as a reference lab. And if we send a lab test to be done, we're going to enter the charge for our claim. But if that test has a reflex, which means that the specimen found something that requires another test, a second test is ordered by LabCorp, and we pay LabCorp for it, and we didn't capture that charge. It didn't get on the claim. So that's just an example of all these hidden little loopholes where you need to go in and look at problems, find out why are we paying LabCorp this much money and we're only claiming this much. So there's dozens of different scenarios like this that my team loves to get in and find and solve problems and refine. Uh, Along the lines of QIP, it's quality incentives. So it does push you to do quality processes, and it's going to encourage you to clean up your processes. So you're going to be saving money. Plus, at the end of the day, your community is getting the care that they need for the quality incentives. We're looking at cancers, we're preventative care. But then at the end, you get a prize for all that hard work. So it's really win-win-win. It's just a lot of work. And we have that expertise to get in and generate those reports. Make sure that the processes in Cerner or whatever system you have match that quality. So there's a lot of different steps, and that's why there's a big burden to get it implemented. But that's what our team does.
So it sounds like what I'm hearing is it's not new funding per se. It's really about recapturing existing dollars, fixing these small process gaps, and it really can mean the difference between being in the red or in the black.
Absolutely.
Yeah. So, Dr. Swanson, rural hospitals, they're often the heart of their community. So how do you balance care quality with some of the financial realities that Doug and Cody have described?
Well, as I mentioned before, emergency departments don't turn patients away in the United States, and most care is delivered without immediate reference to the cost. We on the clinician side, there's a separation that's pretty significant between the clinical side and the financial side, um, and so hopefully uh, the quality of care will be continued to be maintained. Um, if there's staffing, if there's a staffing loss, that can certainly affect delivery of care. But again, the big issue I think is uh, individuals who lose insurance coverage and are not able to uh, schedule um, routine medical care. Uh, And and then on the other side, just maintaining the long-term viability of the hospital. Um, but I would expect that going through this, we will continue to be able to deliver care in a way that will be as good as we have, and I would hope that we would not have any loss of quality of care despite these financial challenges.
So, Doug, for situations where you might, it's a struggling hospital and maybe they're in the red, are underwater a little bit, what would be some suggestions, or how would you manage that situation? What would you suggest?
Well, I think you certainly diagnosing where use the term hemorrhaging. Where are you seeing um, the biggest revenue losses, and what are they being attributed to? In many cases, rural hospitals are really struggling just from a staffing standpoint. So the reliance on the use of travelers, et cetera, is increasing the expense base. We actually went through and took a look at every expense area that we had, starting with the largest ones, to see where could we get some dollar savings. It's amazing over the course of time, if you've been with your organization for 10 years, and with so many changes, how often there will be some simple things just in terms of contracts that are no longer in use, but for some reason are still getting billed through your AP system. Those were just real easy, low hanging fruit areas for us. But then for larger areas within departments, really what is causing the negative net income impact? And how can you align all the resources that you have, the IT resources, et cetera, to try to mitigate as much of that to get to a break even point as possible. And so, um, for us, we've spent several years talking about, uh, outside of intergovernmental transfers, provider taxes, other kinds of programs. Without those, how would we run a break even operation? Really looking at the detail and what's causing us either to be able to get there or to have some barriers to accomplishing that. So I think it really is getting into the detail and utilizing all the resources you have available.
That makes sense. Now, Doug, you've been kind of vocal about keeping transparency and morale high. So, how do you communicate confidence to your team members and community when the headlines are talking about closures?
Well, it's interesting. I think the day after the HR1 or the Big Beautiful Bill was signed, I actually had family members reach out to me and say, what does this mean for your organization? And more importantly, do I need to move my loved one? And so I think we are barraged with information and in some cases misinformation through all types of various media outlets. And in the current political climate, it just creates this enormous amount of anxiety and tension, not only with our patients and our community members, but also with our staff. And so we have really taken a focus on over communicating, first understanding from a layperson's perspective, what does it mean? We have spent years, basically since COVID, trying to put ourselves in a position where we can weather the storm, so to speak. And I think it was important for us to communicate that in a way that was digestible with our community. That we're in a good, stable position, and here's our strategy going forward, so that they did not have that same anxiety level. And then, as I said, the closest healthcare resources, are 40 miles away. So, creating that sense of calm, I think, helped. But it's that continuous messaging over and over. So we utilize social media. We utilize our newsletter systems. We've made video series on our websites, both for our employees as well as for our community members, just to help educate them on the true reality in our area.
Yeah, super important to keep that communication going. Cody, I mean, let's talk a little bit about the approach. It's almost like it's concierge level support almost. Training physicians one on one for 30 plus hours, sitting shoulder to shoulder with clinicians. Can you talk about the impact of that, and why does that matter?
Definitely. Our hospital, Eastern Plumas Healthcare, as a critical access hospital, it's tiny. The emergency room physician is also the hospitalist. So, like everyone else at a critical access hospital, everyone wears multiple hats. And a lot of times these providers come in and they've learned a half dozen different EHRs, and it's very hard to learn the workflows and how each particular system works. So when we onboard a new emergency room physician, there's a lot of pre-training, and then the day that they go live, I'm at the elbow getting them through some patients, and then I'm available afterwards at midnight to help admit a patient for sepsis. It's a matter of They know how to practice the medicine. They went to school to practice medicine, and then they got to write a book report about every single patient that they worked on. And that's the hard part. And software is supposed to be tools, and these tools should facilitate medicine and make it easier. And sometimes it's backwards, where that is the biggest barrier to caring for your patient. And that's where IT and more what our team does in the informatics and processes is make the tools actually work for you. And that emergency room physician is the king of the ship for 48 hours. And anything we can do to help support them and remove barriers from their practicing medicine is going to make everything better for them, for the whole hospital, and for the patients in the community.
Great work there. Dr. Swanson, can you talk a little bit about, from your perspective, the importance of this onboarding process for new emergency room physicians?
IT has been absolutely crucial for making the process work. We've got a small hospital with a small emergency department, relatively low volume, and um, we're in a very rural area. So I have a number of physicians that are driving long distances to get to our hospital. They'll do one 48-hour shift a month in some cases. And these are very experienced physicians that are working at large facilities and are for instance, might be quite expert at the use of Epic, but they haven't used Cerner, which we're using. And so coming once a month, it's a little different than being at it every day, 5 days a week. And so having IT there first for the initial training, and then to help with the kind of detailed minutia of admitting a patient has been really invaluable. Um, the uh, the process of learning a system so that it actually gets into the motor memory when you're just at it once a month it can be difficult. And I think if we didn't have IT backup, it would be much harder to have the process go smoothly.
Yeah, that's super important. So as we kind of focus more towards the future now, Doug, maybe you can talk a little bit about, what's the next 12 months look like for rural hospitals, and where would leaders need to focus, or where do you suggest they focus?
Well, I think some of the key takeaways, we actually started our process last January. All the signs were pointing towards that this year was going to be the target year for Capitol Hill to look at healthcare funding. So we worked with ITS to identify some of our exposure areas or opportunity areas. Cody touched on non-reimbursable revenue codes. We looked at areas that we had overlooked, such as advanced beneficiary notices, which helps us to avoid our write-offs. And as we've talked about, how do we get the best maximization out of our EMR system? We made the switch in 2023, and that required really looking at rebuilding everything from a rev cycle perspective to make sure we were capturing everything. I would say, in terms of some key takeaways, in my opinion, 2026 is really the year to align processes and resources to capitalize available revenue opportunities, promote efficiencies, and many of these, what we found, are very complex, and they'll take several months and multiple department resources to be able to operationalize. I'd recommend, gathering your subject matter experts. We've been very lucky to have Cody on our team for a number of years, as well as his group, to figure out where are your best opportunities. Um, we've taken a look over the last 6 months at what services can be centralized, anything from referral management, scheduling, the authorization process. In many cases, we found that we were duplicating those services across 8 different departments to varying levels of success. So, how can those potentially be centralized without requiring any increase in FTEs? And are our systems producing the data that we need to help manage our operations in real time? I think that's one of the biggest challenges. Is a lot of times there's data, but how do we turn that data into information that's valuable? Um, we talked a little bit about some of the quality improvement initiatives and those payments as a result. We struggled for quite a while just to be able to collect and report on 1 to 2 measures, and next calendar year we're planning to report on 7 to 8. with each of those metrics carrying a value of somewhere around $400,000 to the organization. So the ability to coordinate software practices, IT resources, et cetera, that has a significant impact on trying to mitigate some of the HR1 impacts. Um, as talked about earlier, identifying service departments that are operating in the red, what can be done to minimize those losses without having to eliminate the service, and then streamlining our operation, both through the use of technology, shared services, and again, the goal is to maintain our employees, but do more with what we have versus continuing to either have an increase in resource expense to get the same outcome. How can we do more with the people that we have currently? So, a lot of different areas, but I really think 2026, the big impacts that all of us are going to see from HR1 really start in 27, 28. So it gives us, that one calendar year to really dig in and try to get those in place so that everybody's hitting the ground running when the larger cuts occur.
Yeah, no, super important points. Cody, as you look forward to the future of health IT, what are some of the blind spots that you're seeing in, hospitals and other medical facilities? Where can a hospital get some quick wins?
Sure. If we were to step into a new hospital, the first steps would be learn that hospital process. Every single hospital is different. As much as you may want to try and standardize it, everyone has something that's unique. So you need to be able to accommodate that. Uh, what we would do just to get into the nitty gritty is probably start at claim generation and work backwards from there. If we can clean up those processes, get the billing rules, get the claim rules, repeatable processes are not a manual process anymore. Speed up your billers so they can actually work on those queues and make sure that they know how to use the software. These things are very big, they're convoluted. If you just moved from one system you've been using for a decade to a brand new system that does everything different and backwards in a confusing way, and you don't have a resource that's really going to help you understand it, you're just going to be a little lost. And that's where we can step in is we learned it. We've rebuilt it. We're going to continuously refine it. And that's what we like to do. It's our passion is to dig into these processes. We love healthcare. We love learning how the whole sausage is made and all the different steps and identifying the different pieces that we can fix. The quality incentive programs are great because it's a challenge. Hey, report on cervical cancer screening. Now we have to look at the entire process and find all the holes and patch those holes and fix it so that now not only are we encouraging the providers to make sure that they check their patients, that they're getting screening in a timely manner, we're collecting that data, we're reporting that data, and it's all a very heavy lift for a critical access hospital without support. And that's where we can come in is we want to learn how you practice medicine, how you run your hospital, and facilitate that and speed it up so that you're a tighter running ship.
Good stuff, Cody. So what are next steps if folks are interested in or wanting to minimize their risk? What can you offer?
Definitely, like you say there, let's have a conversation. Let's meet and talk. If you're another Cerner I client that went through the same fun implementation process that we did and kind of forced processes that were changed, Cerner is a clinically driven revenue cycle, which moved the burden of everything onto clinicians. And it can be clever if it works, but it's also very hard to make sure that you're capturing every single charge. So yeah, it'd be best to schedule a meeting. Let's just have a conversation. Let's learn. We're happy to, share some skills, some quick ticks, and some ideas. We want everyone to be successful. If you want us to do it, we're here for you. We can contract with you and start to dig in and fix some of these problems. Because we were lucky enough to be in at the very beginning with Eastern Plumas Healthcare and rebuilt that hospital from scratch when you build a new EHR. And that was quite the ordeal, and we're still refining that process. But we learned so much by doing that. And we know there's many other hospitals that got the same setup, the same implementation that may not have been as thorough as they wanted it to be. And once it's implemented, it's yours. You own it. You have to try and work with it. And that's where we can come in to help at pretty much every single piece of it. We can help with your lab. We can help with radiology, interfaces, We love all of this stuff, and we have a big passion for it, which might confuse a lot of people because we just absolutely get in and figure it out. And we don't know, we don't say it's not our job. We might say, I don't know, and we'll say, let's figure it out together. And we're quite successful at that.
Yeah, great. Thank you. So you can go ahead and drop an email to healthcare@itsasap.com or scan that QR code. Alrighty. So we have some questions that have come in. So I'll go ahead and start with those, and whoever would like to chime in, feel free. First one that came in is, how can technology improve care continuity without adding burden to clinicians? Someone want to take that one?
Well, I'll jump in first. I think one of the things that all rural operators struggle with is just physician availability. It's a difficult area to recruit. Uh, Physicians that serve rural communities really do so out of a love for the community and really give of themselves. But how do we make their level of frustration with the management of EMR systems, et cetera, how do we limit that as much as possible? And one of the things that I think colleagues on the call might go through is we are barraged with the latest AI technology, and a lot of that is not vetted. And so it's difficult to determine what the return on investment is. It's been helpful to work with Cody's team on implementation of things. For example, we have just launched AI provider documentation, and we're showing that that's having a 1 to 1.5 hour per day time savings for our physicians. So instead of being here late to the evening, they're able to actually get out on time. It's helped certainly with chart closure, improved documentation, but really trying to do what we can to allow them to be able to spend more time with their patients, but not have those extra burdens on trying to deal with the tech side.
Let's see. What can small hospitals do to strengthen eligibility renewals with limited staff?
Well, again, happy to take that one as well, because that was one of our biggest concerns. Sort of ties back to when I was sharing the concern about the number of Californians that they're projecting will fall off the rolls. So, like one of the things that's been successful for us that I'd recommend is we've been doing extensive community education sessions. Uh, Understanding the benefits that you currently have, understanding what's required to be able to access new benefits. And those have been very helpful. And we've been able to actually collaborate with uh, a bank system, with an attorney group that specializes in setting up those kinds of applications. The other part is it's going to require, now that we're going from a 12-month eligibility process to a 6-month, is expanding your eligibility team without looking to necessarily add additional FTEs. So, it, and what that's done is, as we've created more efficiencies in certain departments, it's allowed some of our high performing finance and business office staff to be able to start learning the eligibility piece so we can touch more of our patients on a consistent basis. So I think those would be two strategies on trying to make sure that people that are on the rolls stay on the rolls, and that community members that may need services understand what their opportunities and options are.
Cool. Thank you. Is there any recommended KPIs that you might track monthly to spot early signs of financial stress?
Well, again, as the operations leader, I'll take that one as well. I think one of the things that has been helpful, and Cody and team have been very helpful with this, is again trying to maximize the information that you can pull from your system or modify it in a way that's helpful for you to be able to make decisions a little bit more quickly. So, we use a lot of year over year revenue and expense trending that helps us on a monthly basis determine, is our train still on the track, or is it heading off in a different direction? These days, with the significant reduction in revenue, looking at days cash on hand and AR and those trends also is incredibly important, because I think Dr. Swanson brought it up. I mean, it really is maintaining your cash base so you're in a good position going forward. And then looking at volume trending, census, patient visits, no-show rates, how your EMR might be able to help with that with scheduling. And what I found is that it's helpful for managers. A lot of managers are clinicians and they train to provide care, not necessarily to understand financial reports. So just giving them some very simple key daily indicators. For example, in the clinic, how many clinic visits do I need to cover my overhead? So just give me a simple number. I need to have 25 people come through today to cover my provider cost, my staffing cost, etc. And I think that makes it a little bit easier to manage the day versus waiting until you're 2 weeks into the next month to look back and determine what happened. It makes you a little bit more agile to make some decisions.
Cody, maybe this one might be for you. Is it possible for ITS to assist with onboarding providers with any EHR? Are you able to help construct the most effective workflows and patient templates?
Definitely. For Eastern Plumas Healthcare, we work with Cerner, Point Click Care, Dentrix for dental. We have also used American Health Tech, and Centric was an old EHR that was sunset. And really, we consider ourselves EHR agnostic because we'll figure it out. And really, the key to it is understanding those workflows. And with physicians and onboarding them, we do really strive to understand how they work, what their workflow is. And Cerner has its own way of doing things, but there's also the provider and finding ways that those two can work together with the templates. What's the best way to speed up your dictation, your notes? Do you have your favorites list? Do you know what's going on? And also, in addition to onboarding, training is an ongoing process. So we do a lot of follow up. Recently, I met with a doctor and said, "Did you know you can launch the images from the report?" Oh, I've been going around to try and get to that. Simple little things, skill shares. Everyone's head down, working really hard, and having just a fresh moment of sitting at the elbow and saying, "Did you know you can see that? Hey, if we sort this, it'll look a little bit better for you." So the key to it is understanding their workflows and then making the tool work for them. And that's kind of where we excel. We're not clinicians, but we really love clinical processes. We'll say we're kind of clinical nerds. So we really strive to understand how that physician or provider works and try and make the tools work with them as best as possible and embrace new technology. That AI dictation kind of flips the script on how you work. And it's looking really interesting, but it's not for everybody too.
Yeah, cool. Good stuff. Another question came in. When 10% of your revenue disappears, where would you start looking for savings first?
Well, in this case, that's the reality for us. So I think we would identify first the low hanging fruit with the highest impact potential. So one of the things I talked about advanced beneficiary notices. That process, as we were diving into that whole rev cycle end to end, I think it was Cody and team that identified you've got some breaks with your ABN process, and you've got $1 million that's at potential exposure risk for bad debt. So, and all that really took then was just making sure that we shored that process up. We didn't have to really do anything differently. We just needed to make sure that it was functioning properly. And that then leads to other identified shortcomings in the revenue cycle from end to end. And I think also making sure what I'm finding to be successful is making sure that managers understand the why and the what about process improvement. Again, it goes back to not necessarily coming to that position with a lot of financial acumen. So understanding how it all fits and receiving the training and the support. And that's where Cody and team's been very helpful on how to get, fit those pieces together. We found that had immediate beneficial financial impacts to us, both for overall volume as well as revenue.
Cool. Cody, anything you want to add to that, or?
No, I think you kind of nailed all the bits and pieces. It's hard to digest a gigantic, complicated process and simplify it, but to say that we love giant, complicated processes and we attempt to simplify them.
Cool. All right, we'll give it another couple seconds, see if anybody else chimes in with any other questions. In the meantime, I want to thank Doug and Cody and Dr. Paul for joining us today and sharing your wisdom and expertise today with everybody here. Give another 10 seconds here, see if anybody else was. Yep.
I'll offer just a little plug here.
Yeah.
I've been very impressed with all of the staff of ITS the entire time they've worked with Eastern Plumas Hospital, in that everyone has had a can-do attitude. I've never once encountered a situation where there was kind of the response, that's not our problem, or we can't handle it, or that's someone else's job. Never once. People have always really sought to understand the root of the problem and to help in every way possible. And it's really been it's been a great working relationship.
That's awesome. Thank you very much. All righty. So I guess with that, we'll wrap it up. And thank you, everybody, for your time. Hopefully it's helpful. And we'll see you on the next go round. Everybody have a great rest of your day.
Thank you.
Thank you.
Thank
Thank
you.
you, Rob.